Good morning. My name is Noel Wilkins. It's my honor to serve as Provost and Executive Vice Chancellor for Academic Affairs here at the University of Mississippi. And while I'm certainly proud to serve as the Chief Academic Officer for the university, I am equally proud to hold a faculty appointment in the School of Pharmacy. Welcome to the Charles W. Hartman Memorial Lecture. I bring greetings on behalf of Interim Chancellor Larry Sparks and the entire university administration. The university and its efforts and the things that we do here are possible because of the students, the faculty, the staff, the alums, and people who dedicate their talents to our mission. This is a human, a social endeavor. And what happens here is the most important thing. It's more important than the structure, it's more important than the facilities, it's more important than anything else around the physical campus of the university. Dr. Charles Hartman was a testament to this. In his short 9-year tenure, he fostered the vision of an institution that could understand the wonderful benefits of natural products and how this work can improve the state of Mississippi and the nation. His vision and efforts to have a school of pharmacy that benefits the citizens and conducts research that is relevant to the nation and the world continues today. It is easy to get distracted by the noise of the politics, the noise of the ideological arguments that seem to drown out the positive stories of change, the positive stories of discovery, and the amazing stories of transformation that play out every single day on our campus. Today, it is my hope that by attending a lecture named for a person who altered the trajectory of this school and university in a profound way, you will reflect on your roles. I encourage you to reflect on what special talent you bring, what difference you can make to these efforts, and think about the powerful influence that we have on each other as we pursue this incredibly important mission. It is through these efforts that our institution is defined. Similarly, it's through the efforts of dedicated, committed, and talented people that our profession is defined and pharmacy advances. I will also go so far as to say, you choose to practice and how you choose to practice, and how you choose to interact with others and engage in the profession is going to contribute to the profession. It's going to contribute to how others view and interpret and understand the profession. You matter. Your practice will matter. And the way in which you care for others will matter to them and define how they understand and how they define the profession that we're all part of. Dr. Michael Maddux, who will be introduced shortly, has played a prominent role in the definition, practice, and profession, and I'm honored to welcome him to our university, and I look forward to his comments. Thank you.
Thank you very much, Noel. We're incredibly proud to call you one of our own. Well, good morning, everyone. On behalf of the School of Pharmacy, I'd like to thank you for attending the annual Charles W. Hartman Memorial Lecture. The School of Pharmacy started this lecture series in 1973 to honor our school's third dean, Charles W. Hartman. Dean Hartman's tenure was tragically cut short by an automobile accident nearly 49 years ago. Today, we remember Dean Hartman for his many accomplishments on behalf of the School of Pharmacy, pharmacy education, and the field of pharmaceutical research. Charles Hartman was born in Alabama in 1924 and served as a pharmacist mate in the U.S. Navy and in the Marine Corps. After his service, he received his pharmacy and master's degrees from the University of Georgia. He then earned his PhD from the University of Florida in 1956 and joined the University of Georgia's pharmacy faculty thereafter. Just 5 short years later, he became Dean of the University of Mississippi School of Pharmacy and immediately set about advancing it even further. He secured funds to construct Faisal Hall, which today serves as one of the main buildings of our school on campus. He also created our Research Institute of Pharmaceutical Sciences, now a world-renowned institute that comprises 4 thriving research centers. Dean Hartman's research interests range from drug absorption to pharmacy administration, and he was granted 8 pharmacy patents throughout his life related to numerous investigations. He also served as Vice President of the Mississippi Association of Mental Health and was a consultant to the U.S. Public Health Service. He was active in the American Pharmacists Association as well as other professional groups. Tragically, this champion of pharmacy, pharmaceutical research, and the pharmacy profession was installed as Vice President of the American Association of Colleges of Pharmacy only 5 days before his death. The late Ron Bourne, a faculty member hired by Dean Hartman, called him a true visionary, a dreamer, a goal setter, a goal achiever, a doer, and a leader. He said that Dean Hartman was a motivator who believed in us and had us believing in one another. Charles W. Hartman had a profound impact on the School of Pharmacy. We are proud to honor his legacy today and to celebrate his many contributions to our school, our profession, and our state. Please join me in acknowledging Charles W. Hartman. And now Dr. Katie Barber, President of the Mississippi College of Clinical Pharmacy and Assistant Professor of Pharmacy Practice, will introduce our speaker. Katie?
Thank you, David. It is with great pleasure that I introduce our guest lecturer, Dr. Michael Maddux, Executive Director of the American College of Clinical Pharmacy. Dr. Maddux received his Doctor of Pharmacy degree from the University of California, San Francisco in 1979 and went on to complete a clinical pharmacy residency at the University of Illinois Medical Center in Chicago. He served on the UIC clinical pharmacy faculty from 1980 to 1991, where he practiced and conducted research in solid organ transplantation. He then joined the St. Louis College of Pharmacy as a professor, director of the Division of Pharmacy Practice, and assistant dean for clinical development before transitioning to executive director of ACCP in 2004. Dr. Maddux serves as the secretary-treasurer of the Pharmacotherapy Publications Board of Directors, secretary of ACCP Political Action Committee's Governing Council, and a member of the Board of Trustees of the ACCP Foundation. He has received awards for practice, teaching, and leadership, including the ACCP Clinical Practice Award, the University of California San Francisco Pharmacy Alumni Association's Distinguished Alumnus of the Year Award, and the Robert G. Leonard Memorial Lecture Award. His publications have focused on clinical problems, pharmacotherapy in the organ transplant patient, ability-based education, and curriculum assessment. Today, Dr. Maddux will be speaking on professional transformation through the lens of clinical pharmacy, deja vu all over again, and we are thrilled to be hearing from him. Please join me in welcoming him to the lectern.
Good morning. First, thanks, Katie, for that nice introduction, with or without an easy page turn. Let me preface my remarks by first of all thanking Dean Allen for inviting me to give this lecture, and also to tell you personally, since I'm a member of the Board of Visitors of this School of Pharmacy, I make fairly frequent trips here, and I have been universally impressed with both the faculty and the students, of course, and the staff here, both in Oxford and in Jackson. I feel like, excluding the alumni who have given this lecture, I have some fairly good insight into the university compared to maybe past speakers. So I'll try to do the best I can to try to target this particular lecture toward those of you who are in the audience and to the University of Mississippi. So, without further ado, let's move forward and see what we can do here. This will be our agenda. I want to take a few minutes to bore the students with the history of clinical pharmacy, because as you all know, history is only of interest to those of us who are fairly long in the tooth. But then we'll spend a little bit of time talking about today's practice and practice competencies, the current state of education, training, and professional development within our discipline, how we're progressing, or if we're progressing, in our efforts to transform practice, education, training, and the maintenance of professional competence. And in that regard, that's partly where the title for this talk comes from. Is much of this new, or is some of it just deja vu all over again? And then last but not least, we'll see if we can pull it all together with a few questions and some implications and conclusions. Well, this is where clinical pharmacy's roots lie. And none of the individuals depicted on this slide will probably be recognizable to the students, but they will be to a few members of the audience who are faculty here. And I'm not going to go through each of these photos, but they largely trace who the historical icons are, both for clinical pharmacy and to some extent for pharmacy itself. I want to take a minute to talk about the organization that I serve, the American College of Clinical Pharmacy, because it parallels in its history the growth also of the discipline of clinical pharmacy. You can see that we were formed 40 years ago now. We will celebrate our 40th anniversary this October at our annual meeting in New York City, with just 29 individuals who decided that there needed to be a clinical pharmacy organization. And today we number more than 17,000. And you can see we have achieved fairly rapid growth, particularly over the last decade or so. This is a purpose statement that actually comes from ACCP's bylaws, and we're not going to read through this, but I want to draw your attention to the bolded bullet. As I say, this is extracted directly from ACCP's bylaws, but it says that this organization's purpose is to promote the rational use of drugs in society, and even today, we continue to use that kind of language when we talk about rational pharmacotherapy. I think that is indeed what our mission is as a group of clinical pharmacists within the profession, and ought to be, I think, the mission of the profession at large, and certainly is becoming more and more the day-to-day mission of the profession as we move forward. Probably, we would say that for those of you students sitting in the audience, this will indeed be your primary focus, or the focus at least of most of your peers in the profession, by the time you reach my age, which will be a really long time from now. What is clinical pharmacy anyway? It's been defined over the years in many, many different ways, but ACCP, despite the fact that it was a clinical pharmacy organization, very adroitly decided to avoid ever defining it until we published this paper in 2008. And there was a question about that within our organization. You know, one faction within the organization said, you know, we should have a definition of clinical pharmacy because no one really knows exactly what clinical pharmacy is. But there was maybe a wiser contingent within the organization that said, well, you know, there's some advantages to not defining exactly who or what you are. And once you've defined who or what you are, you've also defined who and what you are not. And so it could, in fact, be limiting. Well, the first faction won out over the second, and by the time 2008 rolled around, we had published this definition of clinical pharmacy paper. This is just an excerpt, but the abridged version of the definition of clinical pharmacy is, again, the one that's molded there, which says it's that area concerned with the science and practice, again, of rational medication use. We'll revisit this again toward the end of the talk. There's a book published in 2009, the first edition of this book. The second edition is being prepared now and will be published later this year in 2019, that really traces the history of clinical pharmacy and really overall the transformation of the profession from one that was primarily product-oriented to one that, as you now know, is very much patient-oriented. If you're not familiar with this book, I suggest that you go peruse it sometime. It will walk you through not only the history of the profession, but the history of what was going on in the United States contextually during that period as clinical pharmacy was taking its roots and beginning to grow. Well, believe it or not, this all started as early as the 1950s. And you can see on the slide some examples. Many of you probably don't know that the very first PharmD program was launched in 1950 at the University of Southern California. There's a lot of confusion about that. People often say, well, it was San Francisco where the first PharmD program was in California. That's not true. It was in Los Angeles at Southern Cal. By the time you get to the 1960s, some fairly seminal things, and I only lifted a few items from each of these decades that might be important, but notice the very first one there, the University of Kentucky Drug Information Center. Why would that be important? Well, in the early days, as pharmacists were trying to move from the basement of hospitals where they were responsible for largely preparing medications, and even subsequent to that, filling unit dose cards, they started to do more clinical things. And at that time, those more clinical things were developing drug monographs to get drugs on the formulary or evaluate drugs for consideration for the formulary. And they became fairly involved in that. And that was something that their medical colleagues were very much willing to cede to them, to allow them to do that, because A, it took time, B, it took some literature research, and C, they were reasonably well prepared to be able to prepare those kinds of documents and do that kind of analysis. So these drug information centers were launched, and the very first one was in the University of Kentucky. And this was a seminal event, actually, in the development of clinical pharmacy in the U.S. From that grew an appreciation that, gee, these pharmacists in this drug information center know quite a bit about drugs. And I wonder if it would be useful to have them maybe coming up and helping us do other things. Maybe they could come up and round with us. Maybe they could do other things that would assist us and expand our own knowledge base with regard to drug therapy. So this was a fairly important foundational step. Notice also that probably the first real clinical pharmacy journal at that time, which was called Drug Intelligence, was published in 1967. Prior to that, there really was no clinical pharmacy journal. And so you can see in the 60s, we're just starting to get our act together in terms of organizing ourselves as a clinical discipline. By the time of the 70s, for the first time, clinical faculty were recognized as an actual group within the academy. And so the ACCP section of clinical instructors was formed. Interesting how that was named at the time, but nonetheless, it created a home within academic pharmacy for that growing cadre of faculty that were beginning to teach therapeutics and their clinical applications. Notice at the very bottom, ACCP was founded in 1979, and so again, as I say, we're coming up on 40 years, we're becoming middle-aged. By the 1980s, things were starting to come together in terms of assembling a body of literature. The first pharmacotherapy textbook, or textbooks, I should say, were published. The first one really was pharmacotherapy, although Coda Kimball's Applied Therapeutics had been used in all kinds of sort of paperback forms locally within the UCSF for several years. But it wasn't actually published until '83. But for those of you that refer to pharmacotherapy texts, etc., recognize that there really was no pharmacotherapy or clinical pharmacy textbook until the 1980s. Also, next to last bullet, the term pharmaceutical care was really coined in the late 80s in 1988. And very soon thereafter, pharmaceutical care became kind of the de facto mission of the profession. Well, here now we're starting to get into opportunities for not only expansion of the discipline, but specialization. And you can see by looking here that we first started that. We had the pharmacotherapy specialty, which was originally approved back in the 1980s. Now we're starting to publish other documents and develop other specialties to the point that infectious diseases became an added qualification in the late 80s. So we were starting to specialize or even subspecialize during the course of this decade. By the 2000s, this process was continuing, and in addition to that, you can see that we started to recognize ambulatory care pharmacy as a specialty. Prior to that, most of our focus had been in the inpatient environment. Most of the clinical pharmacists were working in the hospital. By the time of the mid to late 90s, practice started to pop up in the ambulatory care environment. And by the 2000s, it became more and more common, such that there actually was an ambulatory care pharmacy specialty approved at the end of the first decade in the 2000s. Well, that brings us up to where we are now. As a discipline, we have reasonably well-developed postgraduate training programs. We've adopted a JCPP vision statement, JCPP being the Joint Commission of Pharmacy Practitioners, the group that represents all of the national pharmacy organizations and some of the subspecialty organizations. At which point that vision suggests that our primary focus is, once again, rational drug therapy. So the vision is that eventually all of pharmacy will, quote unquote, be clinical. Along the way, we're going to talk about some other things like the standards of practice that now have emerged for clinical pharmacists, and also the need to maybe study our practice in a little bit more rigorous fashion. We'll talk about that in a few moments as well. Okay, time for a pop quiz. Students, take out your papers. Just kidding. Which of the numbers below do you think is most relevant to clinical pharmacy? Actually, which one is relevant to clinical pharmacy? You can see there's a figure there, 9,766. There's a date, 9/7/66. There's a decimal, 9.766, 97.66, and then actually a date at the bottom, 9/7/66. B, I guess, is more of a combination of things. Those numbers probably mean very little to you. Let's take a look, though, and see what the answers might be. Anybody think it's A? Well, let's see. Could it be A? Number of students enrolled in pharmacy schools in 2018. Is that a correct number, do you think? How many students are enrolled in schools of pharmacy? Notice this doesn't say how many graduated. It says the number of students enrolled. Well, first of all, we have about 14,000 graduates annually alone. Now, we probably don't have maybe 14,000 across 4 professional years, but we know that it's a lot more than 9,766. In fact, it is definitely more like 55 to 60,000 currently enrolled in our pharmacy schools in the U.S. So this is not the answer. How about this one? No? Well, that probably can't be, right? So that's not it. How about this? This could be close. This could be close. But although I think most of your faculty and many of your other mentors probably recommend that for the students who will be graduating and have just applied and will be filing, I guess would have just filed their match cards maybe. Is that right? Were match cards due like right now? Probably their advisors said, you probably ought to apply, you probably ought to match at least 10 programs. The problem is most people probably don't get interviews at 10 programs. But the average number of residency applications filed by this year's residency candidates is not nearly that high, even though maybe we hope that it could be, to increase their chances. How about this? The percentage of U.S. graduates who passed the 2017 NAPLEX exam. Well, I hate to tell you, but it's lower than this. Now, at the University of Mississippi, I suspect it's higher for those graduates. But if we looked at the national average, it's not that high. So that isn't the answer either. Well, then I guess by process of elimination, it's this one. September 7th of 1966 is the day that the so-called Night 4 project was launched at the University of California, San Francisco. And what the Night 4 project was an experiment. It was an experiment to take pharmacists from the basement and put them up on the floors and have them make rounds with physicians. This was in an academic medical center at Moffitt in San Francisco, which was the University of California's medical center. And it was a fairly avant-garde effort at the time. There are some individuals who are kind of icons in the profession now who led this effort, and it turned out to be pretty successful, such that all of a sudden there became this identifiable need to have more clinical pharmacists on the floor. And some people point to this particular ninth floor project as really being the genesis of clinical pharmacy practice in the institutional setting. Okay, well, since 1966, how have things changed? Well, let's look at where most clinical pharmacists spend their time today. And I don't think my pointer is going to necessarily work all that well, or whether you can see it. But even today, amongst ACCP members, and this is, I think, a representative cross-section of really all clinical pharmacists, but these data come from our membership in ACCP, still, nearly a third, and the largest cohort here, spend their time in acute care. Notice, though, that the next biggest piece of the pie is really this one in ambulatory care, and this is the most rapidly growing. And for those of you who know anything about healthcare, you know that most healthcare resources are being directed more to the outpatient environment today and away from the acute care environment. That includes both dollars and personnel. Note this little square, though. This is pharmacists practicing in critical care. So if we were to combine critical care and acute care, nearly half of the clinical pharmacists today are practicing in the inpatient environment, and less than 20%, as we say here in the red ambulatory care piece, are in that environment. Meanwhile, we still have a significant number of clinicians who are involved primarily in education of students, a large segment that are doing what we would call other stuff, like what I do for a living, and then administration. How many people are doing predominantly research? Only 4%. And that number rings true pretty much in every school of pharmacy that I visit. One of the things right now, probably amongst those of you sitting in the audience who are students, only 4 out of 100 of you are probably at all interested in pursuing a research career. And you may not even know that yet. So it may be more like only 1 or 2 of you knows that that's what you want to do. Within our organization, only about 5% of our members are really actively engaged in research. So as a discipline, we're predominantly clinicians and practitioners. That's important to keep in mind for further discussion. How has practice evolved? Well, you know, we've gone over the course of time from being largely a set of independent practitioners up here, where physicians are here, pharmacists are here, to maybe an episodic consultant role depicted by the schematic in the middle there, where we occasionally have an interaction with a physician, to today, where we largely practice in a collaborative, team-based environment, where we have frequent interactions. And those of you who have been on IPPEs already, probably, and certainly the students who are on rotations in their APPEs right now, recognize that very much today, medicine and healthcare is a team sport, and that almost always you're practicing in collaboration with 1, 2, 3, 4, or more other health professionals. So this collaborative practice has now largely become the norm for most of us. Whereas back in the day, we were either independent or maybe at most engaged in consultative practice. That means that there need to be some analysis or thought given to what the competencies are of someone who works in a team. And so the Institute of Medicine, now the National Academies of Medicine, have established a set of core competencies for all health professionals that relate to team-based care and the competencies needed to practice in a team-based environment. None of these should be surprising to you, but they apply across the board, whether you're a medical student or a pharmacy student or a nursing student or a student in the other health professions. More and more attention is being given to making certain that our students and graduates possess these competencies, once again, because almost invariably, down the road, you're going to be asked to practice in some type of collaborative environment, regardless of what practice setting you're in. And again, we'll get to some of this down the road here in a second. What exactly is team-based care? Well, this is one definition, and it's a definition that's largely embraced across the board by most healthcare professionals. And again, I think as you read this, you're going to say, yeah, that makes perfect sense and sounds to me not only like the way it should be, like in many instances, the way it actually is. Well, for a team to be able to function and for this collaborative care deal to actually work, you need to have these principles operating. One, there need to be shared roles, and they need to be understood by all members of the team. There has to be a clarity of roles. What am I responsible for? What are you responsible for? And perhaps what together might we be responsible for? That there's mutual trust. That's a biggie, and something not easy to engineer. It occurs through an ongoing working relationship, an appreciation for the knowledge base that one discipline brings to the team versus another, and one's own personal experience in working in these team environments. Obviously, like every place else, effective communication is critical, and last but not least, the team has measurable processes and outcomes. Measurable processes and outcomes. What does that mean? Well, it means that the process of care is well enough described that it can be delivered consistently and it can be delivered in a way that can be measured. What that really means, we'll talk more about at the end of this talk as well. And I think the personal values, these go along with anything from working in a healthcare team to being in Bridge Club, to be honest with you, and working on the church social committee. These are common personal values that make it fun to work with someone else. If they possess these values, they're generally embraced as a valuable member of any team, whether it's in healthcare or not. Last but not least, technician support. A lot of attention has been given, particularly over the last 5 to 10 years, on the role of pharmacy technicians and other support personnel in the delivery of pharmacy services. In many ways, technicians are, in fact, underutilized. But in other ways, they're underutilized because they're undertrained. And so some attention has to be given to not only what technicians should do, but how they are best prepared to do those things. Once they are prepared, the key is to leverage those activities such that they can support the activities of a clinical pharmacist or other members of the team for that matter in the delivery of patient care. And these are examples of the types of things that technicians can and should be able to do at some point as they progress through their career. Neglecting the role of support personnel for any healthcare provider is a huge mistake. Well, let's talk about the current state of education, training, and certification, and maybe some thoughts on what the strengths and weaknesses are of today's professional education within pharmacy. I would say the strengths are the bullets listed on the left there. We've really, I think, established a pretty clear patient care focus. We now provide our students with early practice experiences within this profession. We did not always do that. We're getting better at deploying technology, both in the instructional setting and in other areas of practice, or in preparing students for practice. And I think our teaching methods have improved. It's probably not that common for students to sit in class now, as I did, and just listen to lecture after lecture after lecture. They're more engaged, they're more involved in having to apply the information to either real world or simulated cases. Let's look at the weaknesses, though, for a minute. One of the things that we have done over the course of the last 10 to 20 years is try to make our curricula, particularly the basic science curricula, more relevant or applicable to practice. And that's a good thing. It's also led to more integration of coursework and supposedly in an attempt to try to reduce redundancy or overlap in the curriculum, these things have been laid out. And for those of you who are taking courses now, you know that you hopefully have complementary topics that you cover in a stepwise fashion. The problem sometimes with this, though, in some of the curricula is that it's reduced the depth at which students learn some of these principles. And so they're learning very quickly how to apply them, but they don't always know the reasons behind those applications. And so one thing that could be happening through all of our curricula in healthcare, but in particular in pharmacy, is perhaps a shift away from some of the emphasis on the foundational sciences. Having said that, I think schools like Mississippi have been careful to guard against that. But I will point out that other schools have not. And that leaves a significant deficit in the foundational sciences for some of their graduates. As you know already, there's been a significant growth in the numbers of colleges and schools, and it's put those stresses and strains that I highlight in the bullets under that particular topic. There's also this idea of practice-ready outcome goals. That means for those of you who are students sitting in the audience, the goal is to make you guys practice-ready. The question is, for what kind of practice? And so this term practice-ready is a little bit ambiguous. And of course, nobody is unaware of the fact that in today's environment, we continue to have rising tuition and rising fees across most, not all, but most of the schools of pharmacy. So these are the current strengths and weaknesses, I think. How about postgraduate training? Here we're talking largely about residency training. There's been really significant growth in PGY1 programs and PGY2 programs. The residency matching program has actually been a good thing. It's avoided a lot of problems that occurred before we had a residency matching system. The forecast system is good in terms of being able to allow a central application process to be implemented. And there has been increasing support from schools and colleges of pharmacy of postgraduate training. From a standpoint of providing faculty to support those programs, providing resources to support those programs, those are all things that have helped to drive the necessary expansion of residency training in the U.S. Obviously, the weaknesses, we still have a lot more applicants than we can accommodate. There is still a fairly operational focus with regard to the accreditation standards. They're focused quite often on operational aspects of an institution, not so much maybe the direct patient care. There may be something of a shift away from core clinical competencies, that is core patient care competencies, toward other competencies like leadership and management. And I think there still remains a lack of emphasis, at least within the residency standards, on expanding or acquiring additional clinical and pharmacotherapeutic knowledge. We'll talk more about that in a second. What about board certification? You know, I don't know how much the students in the audience know about board certification, why we have board certification, why is it important, why do people get board certified? But suffice it to say that within the health professions, particularly with our colleagues in medicine, there is an appreciation for the fact that A, one has to demonstrate an adequate knowledge and experience base and be certified that they are competent to be able to practice in that area, whether it's a specialty or a subspecialty. Board certification pretty much is accepted within our healthcare system as being an important quality assurance step. Well, okay, So if we as pharmacy, as a pharmacy profession, are hoping to move to become a credible clinical profession, what's a way that we can demonstrate that credibility? One way is by implementing a fairly rigorous and supportable and demonstrable board certification system. And so that's what we've done. It started out very slow. I mean, you can see even in 2003, we had less than 5,000 board certified pharmacists in the world. This is global data. Well, now in 2018, at the end of the year, we exceeded 40,000 board certified pharmacists. The majority, the blue bar there, is the pharmacotherapy specialty, which I would say is analogous to the internal medicine specialty. Everyone wouldn't agree with me on that, but it is, I think. Why does that matter? Well, it says that we're starting to acquire a critical mass of pharmacists that are board certified in a clinical specialty area, who seemingly have both the knowledge and experience to practice at this level in these clinical types of environments. It's an important step for us, particularly vis-a-vis our colleagues outside of pharmacy. There's also been significant growth in international board certified pharmacists. Most of them, the red piece there, is in pharmacotherapy. You can see these are all the countries where there are board certified pharmacists. So this isn't something just unique to the US, although the vast majority of board certified pharmacists are in the United States. This gives you an idea of the numbers outside of the US. And if you can read the slide, the largest contingent, believe it or not, is in Egypt, where there are more than 1,000 board certified pharmacists, most of them, again, in pharmacotherapy. But notice even a very small country like Singapore, if we were to take Singapore and take the ratio there per capita pharmacists, that's a big number, 418 for what is a small, island nation state or city-state of only a small number of pharmacists, 418 of which are board certified, is fairly remarkable. Well, this is an interesting slide, and I've compiled this slide over the course of several years and sort of traced it over the last, I think I've been doing this for about 5 years, and what this depicts is the annual professional degree programs, annual residency graduates, and annual board certified individuals in any given year. So it's not cumulative. These are the numbers that are happening in any given year. Now, we don't have data for the number of graduates from 2018 yet. Those data have not been completely compiled by the American Association of Colleges of Pharmacy and ACPE. But you can see that there's some parallels here. But the numbers of graduates have increased at a more rapid rate than have the number of residency graduates or the number of board certified individuals. And it's not surprising, is it, that the two bottom curves are more or less superimposed on one another, because it's fairly common these days for residency graduates to then go on and seek board certification. So you would kind of expect there to be a very close relationship between the number of annual residency graduates and the number that are annually board certified. Importantly, notice again at the far end there for the 2018 data, if you look at that red curve, we're well over 4,000 residency graduates per year. That's a pretty significant number in the United States, and this is almost all U.S. data. There are only a couple of international or non-U.S. programs in these data, and in fact, they're so small that they really don't count. So this is really, you should look at this as being all U.S. data. So we can say, well, we don't have enough residencies, but we can also say we're still graduating a significant number of residents these days, and this number, no doubt, is going to continue to climb. Well, okay. So we've traced a little bit of the history, we've traced what's maybe going on in practice, education, and postgraduate training. Does that beg a few questions? It did for ACCP, and I want to take a minute, and I don't think I'm going to take as much time as I had originally planned to talk about some key papers, but I will say something about this 2000 paper, which is on the left-hand side of this slide. It's a white paper that was published in 2000. And so it's really 20 years old because it was written largely in 1998, 1999, or the work done on that paper was done in 1998, 1999. So it's 20 years old. But for ACCP, this paper really set the tone for what the organization was going to do for the next 20 plus years, and it has. And it's kind of unusual to go back and read this paper. It's like a long chapter in the textbook. It's very, very, very long, so it's not a quick read. But it does point out a number of things that were noted by the experts that wrote this paper, and the individuals who authored this paper are people who were involved in the very early development of clinical pharmacy in the U.S. and pharmacy in the U.S. So they were knowledgeable individuals, and what came from this paper actually ended up being very much a template for what ACCP has done, again, over the last 20 or so years. Along the way, I told you about that definition of clinical pharmacy, and that paper, that really sort of lays out what clinical pharmacy is and what clinical pharmacists do. We've also talked about what the requirements would be to be able to provide direct patient care. You know, at one time, there was a misunderstanding about ACCP's position on residency training and board certification. We were often misquoted as saying that, you know, every student, every graduate, should do a residency. No, that really wasn't our position. Our position was that anyone who's going to provide direct patient care should do a residency, should be residency trained, only because the knowledge and experience that comes with providing direct patient care requires more than just a pharmacy degree. And that's pretty much universally accepted across our membership anyway. Same thing with regard to board certification, where we were often misquoted as saying that, well, all pharmacists should become board certified. Once again, not necessarily, only if you're going to be expected to be privileged and to practice within a given specialty area. And most of the time, as you saw from the slide a couple of slides ago, once one completes residency training, usually the next step is board certification. By 2014, the organization decided that there was a need for there to set forth standards for clinical pharmacists. And these standards really address 8 different domain areas that pertain to clinical pharmacy. It's everything from qualifications to how one practices to what one does in terms of engaging in other activities beyond practice, including research, leadership and management, and so forth. Up to this time, there were no such standards for clinical pharmacy anywhere in the world. There were other documents published that alluded to standards for pharmacists, but not that were focused only on clinical practice. That leads us to this, comprehensive medication management. Now, this is a term that many of you have heard of and that some of you may not have heard of or may not fully understand. Most of you have heard of medication therapy management, MTM. But CMM is a little bit different. CMM is what we would call, back in the 1980s, clinical pharmacy practice, or comprehensive clinical pharmacy practice. It means comprehensively managing all of a patient's medications and assuring that they are being optimized. The goal really from our perspective, even though we said, you know, the purpose of clinical pharmacy and clinical pharmacy discipline is to assure rational drug therapy. Well, yeah, you can have rational drug therapy, but if the patient is unable to take it, or if they're unable to acquire the medications, then you can have all the rational therapy you want, but you won't have optimal outcomes. And so this really ultimately is about optimizing medication use, or what we call medication optimization. Most of you are familiar with the JCPP process of care. This is the CMM process of care. They're really more or less the same. We developed them in parallel. ACCP worked very closely with our colleague organizations in developing the JCPP process of care. In fact, we were the reason the JCPP process of care exists. It took us a couple of years to get JCPP to agree that there needed to be a process of care. And then we worked together across all organizations to develop this process. Meanwhile, ACCP had developed one more for clinical pharmacists, and it includes one less step. It sort of incorporates step 1 of the JCPP process into its own step 1. So we consider the collect, what is sometimes called the collect step in the JCPP process of care, as just being all part of the assessment. So these are really very much similar. But this idea that there has to be patient assessment, there has to be some evaluation of the patient's medication therapy, one then has to develop an appropriate plan and implement it. And then last but not least, once that plan is implemented, there needs to be ongoing follow-up and monitoring. This is something that should be rhyme and verse, really, for all of today's students and certainly for today's residents. Well, guess what? ACCP went to our physician colleagues at the American College of Physicians, and we said, you know, we're interested in working with you more closely on identifying ways that we can affect better collaboration between practicing internists and clinical pharmacists. And so the American College of Physicians, at that time, this was a CEO to CEO discussion. So I was talking about this with the CEO of the American College of Physicians, which represents about 170,000 or 175,000 now probably internists in the United States. And so the CEO said to me, okay, we're familiar with what clinical pharmacists do, particularly in the institutional setting, but what would they do in my office? How would that work exactly? And so my colleague and I, who were there at the time, said, well, I mean, these are generally the functions that occur in the office-based environment. And he said, so are there data available on how that's operationalized? We said no. So, well, how do you know it will work? He said, well, we've seen it work. We've seen it benefit patient outcomes. We said, yeah, but for our members in a 1 or 2 or 3 physician office, or maybe in a multi-specialty group that has 25 physicians, how exactly does that work? We said, well, we don't really know. So that led us to go back to the drawing board. This was about that meeting was about, I'll say, in 2013. And so as a part of our planning and discussions, we said, you know, there needs to be more rigorous study of clinical pharmacy practice, particularly in the primary care environment, because there isn't any. What's in the literature is replete with a lot of different one-off examples of how different clinical pharmacists have provided what was called clinical pharmacy services, undefined, to various patients and physician groups. But there was no consistency. There was no easily identified methods with regard to even who or what that clinical pharmacist was or what they were doing. And so we said, gosh, you know, what's missing is a more comprehensive study looking at clinical pharmacists with specific levels of education and training doing specific things in primary care practice. So, together with our colleagues at the PCPCC, which is the Patient-Centered Primary Care Collaborative. It's a group of many, many organizations in and outside of pharmacy. Really, we were the only pharmacy organization. So it's a number of organizations outside healthcare who were responsible for establishing the patient-centered medical home. Again, the new, no longer new, team-based provision of care that primarily is focused on achieving outcomes for its patient population. So we worked with this group to say, would you be interested in trying to figure out how medication therapy management should be done, particularly in a comprehensive way? And so that led to this idea of comprehensive medication management and a definition of what comprehensive medication management should be. But even with that definition, exactly how it was going to be implemented was kind of left to the imagination. So we said, well, you know, we need to do a large-scale study. So we issued a request for applications for people to apply to do a large-scale study across a number of different primary care practices, having clinical pharmacists providing services within those practices. That led to this grant, which ended up being a $2.4 million grant that we awarded in 2015 for a study that began in 2016 and now has run into 2019 and will conclude this June. Out of that study, among other things, has come this, which is what we call the Common Language Document in short term, but it delineates exactly what clinical pharmacists do step by step in the primary care practice environment. And the reason this was important is that in our travels, when we had looked at what people were doing in practice, we were told, yeah, well, that's right, but there is no real consistency here. If you've seen one clinical pharmacist practice, you've seen one clinical pharmacist practice. They all don't do the same thing. That was a flaw in trying to do a systematic study, because if you have people in a study doing an intervention, as we would call it, and they're all doing the intervention differently, then what can you show? So it became very important to define at the outset what CMM, Comprehensive Medication Management, is, and that's what this document did. And it's now what we use as the template for clinical pharmacy practice in the primary care setting. So if someone comes with us and says, you know, I'm going to start a practice in this ambulatory care environment, we say, well, are you familiar with the Common Language Document? This would be the place you would start. This is really the playbook for how one delivers clinical practice in a direct patient care environment in ambulatory care. So, in terms of qualitative or quality progress, how much have we advanced over the past 30 years? I would say in the ambulatory care environment substantially, notwithstanding what I said about the inconsistencies. But we have inconsistencies in the inpatient environment as well. But 30 years ago, we had very little engagement of clinicians in ambulatory care practice. Now, it is the most rapidly growing sector. So I'd say there's substantial advancement there. In community practice, well, it's been significant, but it continues to be limited by many of which are environmental factors in community pharmacy practice today. Acute care practice, I don't think looks a whole lot different than it did 30 years ago. So I'd argue that there's been minimal progress in terms of acute care. In fact, probably the residents today in their residency, in terms of their practice activities, are doing much the same thing that I did in my residency in practice, which was, of course, 40 years ago. How much has professional education advanced over the last 30 years? Well, that to me is kind of a no-brainer. It's advanced a lot, and we didn't retrace that in our history, but many, many things have happened that have markedly improved the degree programs that the students in this room are going through. Much better than what I went through. It's rocket science compared to what I learned. But what's the end game? It's apparently to make you practice ready. But the question is, for what kind of practice? And we would argue a practice that is designed to try to achieve medication optimization. And when we talk about medication optimization, we're talking about, on the left-hand side, devising an optimal regimen for the patient, and on the right-hand side, achieving optimal use. It takes both. As I said before, if the patient is on all the right drugs, but isn't able to get them or isn't able to take them, then they're not going to achieve the intended outcomes. That, we believe, requires cooperation between all sectors of pharmacy, whether one is in an office-based practice or one's in a community pharmacy. The two, no doubt, could be synergistic. This gives you an idea of how you might want to have pharmacist teams, or a pair of pharmacists, or pharmacists across sites taking care of patients, one working mostly on the regimen side, the other one working mostly on the optimal use side. Well, how much has postgraduate training advanced? Well, a lot. Residency training is much better developed. PGY1, PGY2 training didn't even exist 20 years ago. But there's still the challenges that I list on the slide. We still don't have enough programs. We still, in many ways, don't have enough preceptors. So these are all going to be areas that we're going to have to continue to focus on. And competencies. I'll ask you to look at the ACCP website at this paper on clinical pharmacist competencies, because within this paper is a depiction of clinical pharmacist competencies versus physician competencies. And if you look at this slide, you'll see that there are significant parallels. So from ACCP's perspective, what you see on the right-hand side are what we believe are the competencies that a clinical pharmacist should possess, the competencies that residency training should focus on, and that the degree program should help prepare students to achieve. They line up reasonably well. And as you can see, we're talking about, for any clinician, having a set of competencies, as we talked about with the interprofessional competencies earlier, that are quite similar, but maybe just with slightly different areas of emphasis. In your case, the emphasis being pharmacotherapy. In the physician's case, the emphasis being largely clinical medicine. I'm not going to go through this or EPAs today. I suspect that many of you in the audience are well aware of entrustable professional activities. Most people realize that competencies are established, but the way that one determines if one is competent is by practicing them, and EPAs is a way to practice those. And that's a way to demonstrate most of the time that one possesses more than one competency. Most of these entrustable professional activities address more than one competency area. And these are an example of medical school domains for EPAs and pharmacy school domains. Once again, a fair amount of parallelism. In medicine, EPAs have been deployed for quite some time. In pharmacy, they're just beginning. And so we expect there'll be some maturation and further development of these entrustable professional activities, which those of you in the audience are no doubt going to be exposed to and asked to perform over the course of your career before you graduate. Professional certification, yes. As I showed you on the slide, it has progressed substantially. And it is one of the things driving growth on the bottom of this slide of clinical pharmacy internationally, where many international pharmacists are seeking to achieve board certification. Okay, so final slide. Is this deja vu all over again, or are we actually making progress? I think there's no question that those of you in the audience are in a good position who are students. The transformation now is not only likely to occur, it's already occurring. And so in your lifetime as a pharmacist, you will be engaged in, I think, much more advanced activities than most of my peers and I were engaged with during our career. Across the profession, there is progression toward provision of patient care at a reasonable pace, but maybe not nearly as fast as we would hope. As I said, in some practice settings, the way people are practicing today is no different than it was perhaps 30 years ago. But, last bullet, there continues to be a fair amount of innovation. There's improvement in delivery of direct patient care, and the results coming from this comprehensive medication management study are going to be convincing. And they're going to show that provided that one follows that playbook, one can significantly impact patient outcomes. So we will have evidence that using a clinical pharmacist in the primary care environment can benefit patients, can benefit the practice, and can benefit the practitioners themselves, our medical colleagues. It actually improves their quality of life as well. Number one's important, I think. And so every institution who says that they're preparing their students to be practice ready has to say practice ready equals what? The strengthening and refocusing of postgraduate education on direct patient care and the things you need to be able to provide direct patient care is going to be important. I said our residency training in the enterprise has advanced, but we still continue to have work to do, and we have to make sure that as we move forward on the advancement of residency training, we don't dilute it. And last last but not least, certification is becoming not only more and more common, it is perhaps today the best way of assuring competence and maintaining it. Because once you get certified as a specialist, you have to recertify. Now, in pharmacy, you have to recertify every 7 years, which means that every 7 years you have to redemonstrate, or over the course of the 7 years, document that your competence is being maintained. That's important because, as you all know, things change in the environment, particularly with regard to pharmacotherapy and drug therapy. But today, when we talk about continuing professional development or maintenance of competence, the most effective vehicle for that right now is board certification and recertification. Thank you very much. It's a pleasure to be here with you today.
Thank you very much, Dr. Maddux, for being with us today and helping us honor the legacy of Dean Charles Hartman. It was a pleasure to hear your perspective, and we appreciate you being with us. So, with that, we are out of time, and we stand adjourned. Have a great day and a great weekend. Thank you.